Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell Eleanor Blum Patient Family Learning Center at Mass General.
My name's Maria. I'm a public health intern with the Blum Center.
Before we get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has mute if you hear a guest speaker today. If you have any questions for our guest speaker, you may use a chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn over to Maria, who will introduce you all today's guest speaker.
Thanks, Amy. Joining us today is Kevin Knoblock. Kevin is a nurse practitioner in the Division of Gastroenterology at Mass General Hospital. He received training in inpatient and acute gastrointestinal conditions, general gastroenterology, as well as Crohn's disease and ulcerative colitis. He is the manager for nurse practitioner and physician assistant team for the division. He joins us today to give a talk on diverticulitis. Please join us in welcoming Kevin.
Thanks, Maria. Thanks, Amy. Thank you, everyone, for joining in. I hope everyone will find this informational and will learn a couple of things. And as Amy and Maria said, feel free to put things in the chat, and I will be more than happy to answer your questions. So let me see. I'm going to share my slides here, and I have to put it in presentation mode. Then I gotta swap it, I think. Swap. I'll get my little pointer ready. Pointer, laser. Okay, there I am. Off we go. Okay, our agenda. What are we going to cover today? So what is diverticulosis versus diverticulitis? There's a little bit of a difference, and I have jokingly said, I love my mother dearly. She goes around telling everyone, I've got diverticulitis, and I'm like, actually, maybe you do, maybe you don't. We'll get into that. The epidemiology of diverticulosis and diverticulitis, and what do I mean by epidemiology? Who's prone to get this, and why might you get it? Importantly, what sort of signs and symptoms, should you be on the lookout for that you might want to think about calling your doctor's office, or maybe even going to the emergency department for? And then how do we diagnose these conditions? And then when you come and see us, be it in the outpatient office, or if it's the emergency room, what sort of treatment do we offer you, and how do we manage this? Then a lot of patients always are like, how can I prevent this? I don't ever want that from happening again. So we'll talk a little bit about that, and what is the likelihood of recurrence of the condition. And some people might ask, oh, would I ever need surgery for this condition? We'll go over that. And then questions. Again, put them in the chat. I told them to interrupt me if we'd like to answer things in real time. That's great. So off we go. So again, as I said, let's take a step back. What is diverticulosis? What is sort of diverticulitis? So, I just have to shrink myself up here. Okay, diverticulosis. It is technically the condition of having a diverticulum, or singular, or diverticula, plural. Basically, osis ending, I will get into a little more, again, of what this is. The osis ending in medical, terminology is sort of, the condition of having. People have heard of atherosclerosis, arteriosclerosis. It's just sort of the condition of having sort of plaque buildup and things in like the veins and, arteries around the heart. So now diverticulitis. What is diverticulitis? It's when one of those diverticula, plural again, become inflamed or infected. So as you probably know, itis, that's the good old medical sort of the suffix for inflammation. Arthritis, pain in the bone, inflammation in the bone, sinusitis, sinus infection, tendinitis, the tendon getting inflamed, sort of like your tennis elbow. So that's the difference. So diverticulosis is just having it. Diverticulitis is when it sort of gets inflamed and starts causing some issues for you. So let's get into diverticulosis a little bit more. So it is a condition of your colon, which is also known as your large intestine, that causes these small outpouchings, these diverticula. I jokingly call them potholes in your colon or cubby holes. So they are generally asymptomatic, and by that we mean no symptoms whatsoever. We usually discover these like when you get your screening colonoscopy at 45 years old, or later for those who don't get them immediately, or on any colonoscopy we might do for other reasons earlier in life. So just to kind of show you, this little area, this bigger area here is just sort of the last part of your intestine. So here, these lighter pink areas are sort of these outpouchings. Not really great. We'll get into a little bit better visual there. So next slide is, so what is, again, more diverticulosis? So if a surgeon were to like be doing surgery and take a, slice your intestine right down, and a cross section there, where the white arrow is kind of where the food is going through, in and out. The arrow itself is pointing to that outpouching you saw on the other slide. And then if we do a colonoscopy, you can see this is what, here's two of them with the black arrows. You can see there's like just a little bit of a, little pocket there, a little pothole or a little cubby hole there. This one might actually have a little bit of food and stool residue in there, you can see. This is just sort of intestinal fluid there. So as food is traveling along, so this view is our scope is like going up into the intestines here. So food is coming the opposite direction because we go from our scope from below and work our way around. And so as food's traveling towards the screen here, food residue and stool can kind of get caught in these little cubby holes. So that's where then we start transitioning from diverticulosis to diverticulitis if it gets flamed. So again, just these cubby holes are what is known as diverticulosis. So who gets this and why do we get it? So diverticulosis is more common as we get older. And technically the number of them, the number of diverticula, those potholes, can actually increase as we 60, 65, 70. So sort of some rule of thumb. So we think less than or fewer than 20% of people under the age of 40 have them. I think that data is pretty decent. We do a lot of colonoscopies before screening. If people have blood with their stool, it might turn out to be a hemorrhoid, other reasons So a lot of people do get colonoscopies. So we think that fewer than 20% under age 40 really don't have these. A good rule of thumb is 60 at 60. So about 60% of the population, once we hit 60, start to develop these potholes in the colon, the diverticulosis. Males, a little bit more common than females. I didn't want to bore you with other statistics, but populations of color, et cetera, tend to be a little bit more affected than the, Caucasian populations. So, we think of these things, we're kind of, very high paid profilers to figure out, what's going on here and what's your, nationality background, because you might be a little more prone than someone else to get the condition. And then, unfortunately, we think that the colon wall, the large intestine wall, for some of us just gets weak in certain areas. And why that is, we're not quite sure. So this isn't 100% proven yet. And then we believe of like abnormal colonic motility, stronger contractions of the colon. So if you think of you took a balloon and you blew some air into it and tied it off and you squeeze it, air is kind of wanting to go all directions to kind of escape as you squeeze the balloon in the middle. So think of that as like your colon. When food is going through, it's contracting and squeezing to move it along. And that squeezing and then the food residue is like kind of pressing up against the colonic wall. And if there's a weakness there, we think that that might, lead to the condition of having those potholes. Also, the other thing, so the first one, the abnormal colonic motility, a little bit out of our control, but constipation, that could be in our control. So we think maybe straining to have a bowel movement increases your risk. And what do I mean by straining? Kind of, go into the bathroom, you feel like, oh, maybe I need to go. I haven't gone in a day or two, maybe I should go. If you're on the toilet and unfortunately like straining and push to have that bowel movement, you're shunting pressure down there. And again, if there's weakness in the intestinal wall, the colon wall there, we believe that that pressure can cause some of those potholes to sort of to form. Just one last thing on diverticulosis. Again, usually, 99% of the time benign. There's rare occasions when those things can bleed. If that pothole, we believe, is a little too close to a blood vessel, they can open up and people will have painless bleeding. A lot of people came to the emergency room. I was on our inpatient team, rushed down to the emergency room. For us to find a bleeding diverticulum is pretty rare because by the time you prep for a colonoscopy, even if you could come in and chug that whole gallon and clean out your colon and us get in there, the colon prep sort of cleans everything out and it's hard to find. Bleeding diverticulum are very rare in the actual diverticulitis inflamed part. So sometimes we'll just see them. And we've had people who will have constant bleeds that, need some sort of treatment and intervention. Okay, so now what's more diverticulitis? Again, I think we sort of said, it's when one of these potholes, the diverticula, become inflamed, infected, or even microperforation. And what do we mean by microperforation? So if you look here on the right, in the black circle, one of these, potholes has gotten inflamed and red. We think that the microperforation is kind of like a paper cut. You really can't see it. So micro, like under the microscope, that's how small it is. And things will start to leak out. So I like to remind people that think of our GI tract as fancy plumbing. It is literally a tube that goes from our mouth down to our anus, sort of our butt. It is the outside world. As we all know, it's filled with bacteria, good bacteria and some not so good, and they keep each other in check. And everything surrounding that area inside your abdominal cavity is sterile. So if this diverticulum that's infected and inflamed and becomes cut there and stuff leaks out, this is where people start to experience symptoms. And depending how big that, perforation, that cut might be, can lead to like more severe symptoms, which we can talk about shortly. So diverticulitis. Okay, so I've got diverticulosis. My doctor told me, he or she did the colonoscopy. They found these potholes. What next? So we believe, recall that we said about 60 people at 60 years of age. And about 4%, the data would say, of people with the actual potholes will get diverticulitis. So I like figures and diagrams. So here's 100 smiley faces. That's our population today. So there's 100 people. So 60% of that is 60 people. So 60%, so 60 people of those 100 will actually have diverticulosis found on their colonoscopy. Of that, 4% of these people will actually wind up with diverticulitis. So you see from the original population, only about 2.4% will actually end up with a bout of diverticulitis, give or take, but not hugely a common thing, but it does happen. Okay. So what are some of the signs and symptoms that you need to look out for? I'm listing these in order how we will, of the most sort of important, the ones most people will see. So abdominal pain, that is, again, the most common symptom. It's usually constant in nature. And it is usually focal. And by focal, it's usually sort of in one particular area, like your left lower quadrant on the left-hand side. It could technically be anywhere. People can get these potholes, the diverticulosis, anywhere in the colon. The left lower side is the most common, but they can be anywhere. People can get them on the right-hand side, could feel like almost like an appendicitis. So if you're a young person, we might think, oh, is this appendicitis more so than diverticulitis based on their young age? So, that's the number one presenting sign for symptom for a lot of people. Next is nausea. So you just might feel very nauseated in addition to the abdominal pain. Maybe you just have nausea first. Everyone might present a little bit differently. And then vomiting next. If you were eating something and you just, pain too and nausea, vomiting is kind of a, common next thing to happen, unfortunately. Probably one of the two worst symptoms in GI, I think I hate, absolutely. And then fever. So these are the real classic symptoms, we would say. And the fever can range. It could be very low grade, it could be higher. Again, depending on how these symptoms play out, will sort of dictate your course, and we'll talk a little bit more about that. And then finally, I always love these. About 50% of people have, we've seen get constipation. And then about 25 to 35% will have diarrhea in sort of like a diverticulitis episode when they're actually sort of flaring. Again, as we talked about, constipation can predispose you to just getting those diverticulosis, the potholes again. Okay, and then urinary urgency. What is that? Just, I need to go, empty my bladder. I need to go pee really quickly. So about 10 to 15%. And the reason here is that if like the diverticulitis is kind of flaring on the left or the right side, it gets close to the bladder. Could it be irritating to the bladder? And if it gets some collateral damage, it might want to just sort of empty itself. Again, so about, maybe when do you need to go to the ED versus when do you need to go to the doctor's office and just outside? So if people are over 70 years old, the data would say you probably should go to the ED if you're having these symptoms. If you have other medical conditions, again, every person's individual. We have to assess each person individually. So if you have some, quite a few other, like especially heart issues, kidney issues, lung issues, especially like in our GI population, people with Crohn's disease and ulcerative colitis, if they're on a medication that suppresses their immune system, they're not going to be able to fight off this infection. So they might need to come to the ED for a little higher level treatment. If your fever is greater than 100.4, if it's 100.6, maybe you can sneak away, but you should definitely call your doctor's office if your heart rate is going a little bit more than normal. And for us, anything over 100 beats a minute is what we would consider abnormal. And if it feels like it's just kind of racing in your chest and fluttering around, definitely can't hurt to give us a call by any means. And again, if you have underlying heart issues, you might need to be thinking about the emergency room rather than just calling your doctor's office. But again, you can always call us, and then we would probably say, oh, you probably need to go to the emergency room. Okay, so you finally make it to us, either in the office or the emergency department. And I know most people, our emergency department can get a little busy at times. So it's probably good to give us a call. Again, it can't hurt. So some blood tests. So we do what's called, you might hear your doc or someone call it a CBC, a complete blood count. So what we're looking for here is your white blood cells, like, are they elevated? So with most infections, we will see, an elevated white blood cell count. But you can see here in diverticulitis, 45% of the time we've noticed that it's normal. The white blood cells look absolutely normal. So if we just looked at that in isolation, we'd think nothing's going on here whatsoever. The next blood test we reach for is something called the C-reactive protein. It's called CRP for short for us. And it is a generic marker of inflammation anywhere in the body. So we always have to take this with a grain of salt. Could other inflammation in the body going on affect this number? Yes. If we don't think anything else is going on and you're otherwise healthy, then we'd probably think, okay, maybe this is part of this diverticulitis pattern going on. And if the white blood cells are elevated, we're like, okay, something's definitely going on here. And if you're telling us you're having pain on the left lower side and the nausea and vomiting, we're like, okay, check. This is adding up to be diverticulitis. Okay, CAT scan, especially if you're in the emergency department. And if we don't know that you have diverticulosis, you've maybe never had a colonoscopy or you're new here and we don't have that history, we're not going to know anything for the first diagnosis. So CAT scan, we call it CT scan or CAT scan. Obviously, it's a radiology exam. It's to view sort of the abdomen, colon, all the other organs in there. And we would usually do that with intravenous contrast and oral contrast. Sometimes oral contrast can be a little difficult. If you're having abdominal pain and you're nauseated and you're vomiting, you're sure as heck not going to really be able to get down that contrast. But, they'll do the best they can. If not, they'll just use the IV and then they'll see what they find. So some of the, everyone now can read their radiology reports, all of your medical history in our Epic medical record system through your Gateway account. So we'll see sort of inflammatory changes You might see the words fluid collection or fat stranding. These are very common. And might even discuss the outpouchings that they'll see. So, the fluid just builds up. Inflammation kind of will draw fluid, can draw fat on the outside of the intestine towards it when it's in an inflammatory state. So our CAT scan is technically about 99% accurate. And usually, as I was hinting at earlier, if we know you have diverticulosis and you've had diverticulitis episodes in the past, we might not need to get a CAT scan on you. We might just go ahead and treat, because sometimes people are a little more prone than others, why we don't know, to have, additional bouts of diverticulitis. Lastly, if you're in an area where a CAT scan is not available, ultrasound, ideally with a high resolution, it's maybe more widely available if people live out in, far, rural areas. The OnePlus, there's no radiation to it, but we might miss pain from other causes going on. The ultrasound's not nearly as high resolution as a CAT scan and can find a lot more. Okay, now, we've worked it up. Now we're going to treat it. What are we going to do? So we're going to talk first about sort of like uncomplicated diverticulitis, which is the vast majority of the cases where the symptoms that we discussed are not very severe and you're otherwise healthy and you don't have a lot of other medical issues going on. So technically, the first thing is pain management, because that's the big thing people complain about. Like abdominal pain, if it's nagging and gnawing, even at a 4 out of 10, can just really interrupt someone's day, and it's hard to sort of focus. So we really try to reach for Tylenol, also known as acetaminophen, and that's also good for fevers. So if you're having a fever too, Tylenol can be good. Of course, we always say sometimes check with your doctor. If you have liver issues, you might need to be careful with how much Tylenol you take. So just be cognizant of that. Advil is also recommended. That's ibuprofens. So, just the general over the counter. But if you have questions, most definitely, check with your doctor's office. Usually, we'll be telling you what you can take after we've assessed you, even if it's over the phone. Okay. Then kind of a liquid maybe or modified diet is helpful, because if you're having abdominal pain, nausea, and vomiting, who really wants to eat? Not many people. Maybe you can get down some soup. But if people are feeling okay and you can do a pretty regular, diet, nothing too crazy, probably nothing too spicy, you can do a regular diet if it doesn't exacerbate the pain by any means. So that's fine to keep good nutrition. And then technically, believe it or not, antibiotics are not recommended for the average person. They used to be, but now they are not, unless one is immunocompromised. Again, they're on some sort of medication that lowers their immune system, like our Crohn's and ulcerative colitis patients. If you've got comorbidities, like other medical conditions we need to worry about. And if you're over 70, that might automatically kind of put you in there. Again, each person's going to be assessed a little differently. If you're otherwise a really healthy, normal, a 70-year-old person, we maybe might not do antibiotics and see how you go for a couple of days with the pain management and the liquid diet. And then sort of reassess, which I think is my next thing, is reassessment. If we just treat you very conservatively, as I said, without the antibiotics, we want to hear from you in about a week. If there's no improvement, if symptoms are worsening, then we start to worry, could this be a complicated case of diverticulitis? Then we might need to think about antibiotics and maybe having you come to the hospital. Okay. And then, so again, oh wait, did I double this by accident? Oopsie. Oh, or do we have to? Oh, and then colonoscopy. Sorry about that. So after everything is calmed down, in about 6 to 8 weeks, the data would recommend getting a colonoscopy, unless you've had one in the past year. About 6 to 8 weeks to rule out other causes, just in case there's something malignant brewing in the colon that needs to be discovered sooner rather than later. We do not do this during active diverticulitis because there's fear that with the inflammation, the the colon wall being inflamed, we could actually cause a perforation with our scope. It could poke through and cause some damage, and then that would result in surgery. So we don't do it in the active diverticulitis phase. We wait till things calm down, so about 6 to 8 weeks. Again, if you had a colonoscopy in the past year and it looked clean, then we probably do not need to do it. Okay, so that was your uncomplicated. Now, what happens? What's this complicated all about? So we basically only 5% of people will get complicated, and you saw how few people actually get. 2.4% will actually wind up with diverticulitis. So 5% of that, you'd actually need 1,000 people, 1,000 smiley faces to get one complicated diverticulitis. And the CAT scan will usually provide that diagnosis. Maybe not. Maybe it starts off as uncomplicated and then it can progress to complicated. So you got to kind of monitor your own symptoms, be your best advocate, and call the doctor to be like, this isn't getting any better. So what can happen in complicated cases? An obstruction can technically happen, whereas the intestine gets so inflamed, it gets so swollen. Again, think of your intestine, your colon, as sort of a hose, a garden hose. The edge of the water goes down the middle of the hose like your food, but the hose itself, that area can get so inflamed and swollen that the area where the food or the water goes through closes off. And that's kind of like sort of secondary to all the inflammation. So then food can't get through, pain builds up, nausea, vomiting increases. And that is sort of, urgent. You need to be in the hospital to get that fixed pretty quickly. Perforation of the colon. I talked about the micro perforation, and that might cause, the minor symptoms. But if you get a bigger and bigger perforation of that colon, the symptoms we've been discussing can be much worse. And then again, all of that non-sterile sort of bacterial fluid in your colon is leaking out to a sterile area where your body can sort of almost freak out and trying to sort of clear it away. Your blood pressure can drop, your heart rate can go up, fever can, and this could be very dangerous if it is a sizable perforation. People can wind up in the intensive care unit with big perforations, and we see that in other conditions in GI, not just diverticulitis. So abscess. An abscess can form as well. It's just sort of that sort of pothole just getting much worse, and then sort of inflammatory stuff building up around it and just causing a little bit more infectious-like process. So that's another complication. Fistula is sort of a tube that goes from one area to another. Think of it as a straw. So that infected pothole, the diverticula, is sort of inflamed. It might stick to your bladder. It might stick to another part of the colon, and then it creates like a little tube from one area to the other. So if you start to notice brown urine, you might actually have a fistula that's connecting your colon and letting liquid stool get into your bladder, into your urine. So these are sort of complicated cases. We need to get these under control much more quickly and be in the hospital for IV sort of medication treatment. Okay, here we go. Hospitalization, as we've been sort of talking. So, you could be hospitalized if it starts off as uncomplicated, that it doesn't improve sort of thing. Like I said, we want you to get reassessed in about a week just to make sure everything's going the right direction. Urgent surgery could be needed for certain people if that colon perforates and it opens up and things are leaking out, causing a lot of issues, and obstruction as well. We don't want the colon to close up. We want it to stay open. So that could be another urgent reason for surgery. And then again, other severe symptoms and conditions, as mentioned earlier. If your pain's not so bad, but you have a fever of like 102, 103, and you're nauseated and vomiting, yes, that's probably more than enough to get you to the hospital. So we have to, again, take every person individually and assess all of the symptoms in totality to see what do we do with this. Okay, so diverticulitis. Unfortunately, we've seen that people can have lingering, smoldering type symptoms that go on for a while. And then, these sort of, the same symptoms we've been talking about, mostly the pain, I think people do complain about, as I do have here, 45% of people kind of complain about intermittent abdominal discomfort, about up to a year, some people will say, sort of in that same area, but not nearly. Say it was maybe a 4 out of 10. Now it's like this 1 out of 10 that comes back and nags me for an hour here or there, maybe 3 days a month. Up to 33% of people will notice altered bowel habits. So different than what you had before. If you were more constipated, you're maybe a little more diarrhea. If you were diarrhea, maybe you're a little more constipated. And then there is technically in the literature smoldering diverticulitis, which are these kind of awful subclinical cases, which are, it's kind of almost diverticulitis, but it's not quite 100%. But we know, especially if we know you've had it before, then we might think a little bit more about treating it because it is causing constant problem. It's not like you had this once, we treated it, and it never comes back, which happens with most people. But unfortunately, some people will have it. Again, talk to your doctor's office if you're noticing that you went through treatment and this is still kind of, it really just is reminiscent of a prior diverticulitis flare. Okay, you've done all that, got treated. What are my chances of getting this again? I want to prevent it. I don't want to have to go through that again. I don't like the emergency room. I don't like CAT scans. Who does? So the recurrence of diverticulitis, again, this is going to be somewhat dependent on the number of those potholes you have. That one little colonoscopy picture we saw, that one person only had 2. I should have mentioned back then, you could see a cluster of 3 or 4 right next to each other. They could be scattered very minimally throughout the entire colon. Like I said, we could see patches of them. Everyone might be a little different. So of course, just the odds, if you have more potholes, more chances that one of those might get something stuck in there. So the data shows about 22% of people will get a second episode within about 10 years. So that's a pretty long time frame. 22% is decent. However, the range from about 16 to 42 is a pretty wide range. Will get a second episode at some point in their life. And then after your second episode, there's about a 55% chance of a risk of a third episode. I should have reversed those two. So as you can see, if people are prone, like the odds are a little bit against you if you start to get more and more of these. Okay, so can I prevent this? Maybe. Not entirely 100% sure. But we recommend a general healthy lifestyle. If we have a little extra weight, maybe take some of that weight off. Sort of a healthy, high fiber diet, adequate water intake, fluid intake. Obviously, smoking, if you're a smoker, there's thoughts, get rid of that as well, kind of almost a given in this day and age. Prevention of the high fiber diet. A good diet we recommend for most people is sort of the Mediterranean diet. I'm sure the Blum Center has plenty of information on the Mediterranean diet. Very lean meats, chickens, fishes, good vegetables, good cooking oil, not like Crisco or corn oil or stuff like that. Olive oils, avocado oils, etc. Preventing constipation. Again, if there's one thing you can try to also do is you don't want to have those bowel movements where you're pushing to have that bowel movement causing that pressure. So Miralax or other sort of anti-constipation medications, but again, check with your doctor's office which one you should use. I just use this one is over the counter, so you can even get it without calling us. Miralax is a great medication in the sense of it's an osmotic laxative. What does that mean? It really is. It's basically the same stuff we kind of use to prep you for colonoscopies. A colonoscopy prep is kind of an overdose of Miralax per se. Miralax is a salt. It is inert. It just goes through the intestine, makes it to the colon. The colon does not like all that salt. It wants to throw some water at it to dilute the salt, to neutralize it. The body likes nice neutral sort of environment. And then that water helps keep the stool from getting, dried up and caked up in there. So you have an easier bowel movement. There's stool softeners. Again, you should definitely, can't hurt to call, the doctor's office to see what's going on. Okay, now the big one. My friend told me I have to avoid popcorn, nuts, seeds, maybe even strawberries. This was the thinking, but the answer is no. there was a study done of about 48,000 people, and I think it was in the Journal of the American Medical Association. They studied people who avoided all of those things and people who did not avoid these things, who had diverticulosis. Statistically speaking, there was absolutely no difference between the two groups. So we don't want to sort of deprive you of your skinny pop, who I love my skinny pop. I eat a bag a week, nuts of some sorts, seeds, poppy seeds, whatever it might be. You do not have to avoid it. However, if you feel this triggered an episode for you, by all means, maybe you want to limit the amount you do. Again, everyone's a little different. I always tell patients, you know your body better than I do, so educate me as well. So again, take it with a grain of salt, but technically the data shows that the two groups, absolutely no difference. The people who were eating these things got diverticulitis just as frequently as people who avoided them. Okay, do I need surgery? So technically, for uncomplicated cases, absolutely not. Urgent surgery for complicated cases. If you have a perforation and the colon's torn open, yes. If you have a fistula, perhaps. Again, we'll see how people heal when they're in the hospital getting sort of intravenous medications for treatment. There can be some elective surgery for people at risk of developing serious complications from, a bad case of diverticulitis or complicated diverticulitis. Definitely people who are immunocompromised, we might think about this, especially if it's the second or third sort of case. It's just harder for them to fight it off when their immune system is being held back with the medications we're giving them for some other condition. So technically, again, it's not done for people who are immunocompetent. Immunocompetent, that means you're fine. Your immune system is functioning the way it should. And this is regardless of the number of previous episodes. So there was a thought sometimes like, should we do surgery at the third episode? I'm not going to say that it never happens. Again, if it's becoming so problematic for you, even if it was uncomplicated, and this is happening frequently enough, maybe we do think about that. It's a conversation we have along with a surgeon, a colorectal surgeon here, and then we go from there. But some exceptions are people who maybe travel extensively for work and they're on airplanes. I always joke the last place you want to get sick is an airplane. You really can't get off that easily and quickly. And then maybe people who live in remote areas who really are a far distance from a hospital. So again, we have to assess each person individually. Okay, wow, we are done. I think that was everything. So let me stop sharing so I can see. Answer questions. Hopefully I was slow enough. I tried to slow down my normal pace of day to day.
Thank you, Kevin. This was helpful. We are now at the end of the presentation. If you have any questions for Kevin, feel free to enter them in the chat. So I have a question whether diverticulosis can be hereditary.
That is a good question. I am not by any means the expert. I would have to double check. I want to say no. Everything I read for this, I didn't come across anything that said it was hereditary by any means. But let me jot that down. So if people, whoever asked that, wants to reach back out to the center, I can have that data for you. So hereditary.
Thank you. And while you do that, I'll enter the Blum Center email in the chat. Feel free to email us at pflc@partners.org. We have a question regarding food. You mentioned that we don't need to avoid nuts or seeds, but is there any particular food that we need to limit specifically?
No, technically that, really no foods that we know of trigger this per se. It's thought that the fiber kind of creates sort of a nice bigger clump. I jokingly would say kind of like a hair plug or a hairball. So it's not as easy for like little pieces of stool to get in those little cubby holes and get stuck in there. But no, there is really no way per diet to sort of, well, there's no foods, I should say, that one does need to eliminate. But again, like I said, if people are like, I really have done this twice and coincidentally it feels like it was diverticulitis after that, then maybe avoid it.
How about during an actual episode?
Good point. That is one where technically, the recommendations are sort of for a liquid diet. So what we would tell people is really back off. Just let the gut heal a little bit. Sip on some soups or ensure Pedialyte, Gatorade to stay hydrated too. And if you want, you can sort of increase your diet slowly. I would say avoid spicy foods, kind of keep a very bland diet. And two, if you depending on your symptoms, if you're nausea, vomiting, again, you're not going to really be reaching for some spicy Thai food or something like that, I think, in that moment. But yeah, just as is, diet as tolerated is what we would say a lot.
And we have a question whether chronic constipation can put you at higher risk of getting diverticulosis and diverticulitis.
Yes, don't know the actual statistics on it, but again, constipation is one of the known risk factors the more often. And again, when I say constipation, some people will, and I'd have to maybe look that up too to make sure. I can always check with one of my colleagues. It's the straining, we think, where you're really pushing and shunting pressure down in that area. But, I always ask when I'm with patients, they're like, I have constipation. I'm like, what does that mean to you? Because it could be like, I go every day, but I have to push really hard to have that bowel movement, or I might be on the toilet for 5, 10 minutes, or I go every third day, but there's no problem. It just comes out and I'm done. So it could be a little bit different. And, to what I came across, it's really pressure, pressure, pressure. But also having stool kind of linger around for too long in the colon is also, problematic to my knowledge. And I'll double check on that too. I'm so sorry that I don't have that off the top of my head. I jokingly tell patients too, it's like you go away for vacation in July and you forget to take the trash out. It's been sitting there too long. It's stagnant. And you come back and it was 80 degrees and the house was closed up. You open the door and you're like, oh my God, it's rancid in here. You can kind of have a similar sort of effect. If stool is just hanging around too long, you run the risk of some of that stool getting in that sort of, diverticulum, that pocket. And then when the rest of the stool comes out, that might just linger stuck in that little outpouching and you'll get that infection.
Thank you.
You're welcome.
If a person gets multiple diverticulitis episodes, should they worry? Are they at risk for developing other problems?
No, to our knowledge, not. But again, we do recommend, especially after the first episode, the data shows 6 to 8, weeks afterwards when things are calmed down. This is, your first time. The CAT scan is pretty darn accurate, but we just want to make sure there's nothing else going on that we might have not seen on CAT scan to make sure there's nothing malignant, no cancer or anything like that. But to my knowledge, there really are no other. It's just sort of that outpouching that gets inflamed sort of thing. Again, you can, if it opens up, you can get abscesses and other stuff, but, we can correct that, if you come inpatient and get treated. But, does this lead to cancer? To our knowledge, no. But I'll double check that too. Sorry.
Thank you. For folks with mild symptoms of diverticulitis, can that generally be managed through their primary care doctor, or should they see a GI specialist?
Sure. Excellent question. A good primary care provider should definitely be able to, I jokingly say, a lot of general GI, the primary cares are sort of very trained and comfortable with those sorts of things. If they hear these symptoms that we talked about, the abdominal pain, nausea, vomiting, and, smoldering fever, it all adds up pretty easily. They're going to probably get a CAT scan if this is the first time, because we don't know what we're dealing with, or they haven't had a colonoscopy. We don't know they have those, potholes in the colon. If you've had an episode of it in the past and like, oh, this is probably your second bout, we'll do like, the conservative treatment if it's not getting any better. I tell people don't wait a week too. If, you're fine day 1, day 2, and then all of a sudden day 3, the fever really goes up to 102 or the pain increases, don't wait to day 5. You call us when things start to go the wrong direction and, we intervene then. So hopefully did that answer the whole question? I'm sorry.
Yes, thank you.
Good, good, good.
Are there online resources that you can recommend for someone to go to learn more about it?
Yeah, goodness. You know what? I should have thought of that. I didn't even think. I always tell, let me look. too, you can always call, the average person doesn't have access to up to date. But up to date is sort of our, I call it those idiots guides you can buy at the bookstore or so up to date has patient information. It's very, patient friendly language. You can ask your doc, but if you Google, make sure you're getting it from a good reputable source wherever it's from. Sometimes patient blogs can get a little cranky and angry, but the American College of Gastroenterology might be a little too, focused. Usually the National Institute of Health has some decent databases. If you just Google what is diverticulosis, what is diverticulitis, if it's like an NIH site or anything. But let me see if I can find some good resources to give to you, and then you can have them at your fingertips.
That'd be wonderful. Thank you. And the Blum Center is always a resource too. So if you're interested in learning more about a specific health condition, you mentioned the Mediterranean diet, feel free to reach out to us. So I will see if there are any additional questions. Are there any final thoughts you'd like to share with the audience?
Again, the big thing is everyone's different. Don't rely on, oh, my friend didn't go into the hospital or my friend didn't need antibiotics. You're different than your friend. You just want to make sure, if you're a trained healthcare person, you're probably not on here unless a colleague of mine or two is being polite and signing in. But yeah, you just want to make sure someone's looking at you in totality to make that decision for you. Because, sometimes people are all well-meaning and they like, oh yeah, you can't eat popcorn or you should not be eating that. Like, those of us who are trained, like we kind of chuckle like, oh, how did that information get out there? Or who told you that? Who, no, get that out of your head and wipe that out. So just make sure, like, if it's causing you some concern, you're like, if you're kind of doing that, call your doctor's office, send us a message to the computer, whatever works for you. We really need to know because, it's usually uncomplicated, but if it gets complicated or gets complicated fast, like it can be very urgent. So we'd rather know about it sooner rather than later sort of thing.
Absolutely. Thank you so much. This was extremely helpful.
Okay, perfect. Glad. So I will get back to you with some of these homework items I have. Sorry, I didn't have them at my fingertips.
Thank you. And for everyone who joined us today, thank you so much. Hopefully you found today's session helpful. As I had mentioned, this session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. And as I had mentioned also, if you have any, if you want a copy of any of these resources that Kevin will share with me, feel free to email the Blum Center at pflc@partners.org. Thank you, everyone.
Thanks, everyone.
Take care.
Bye-bye.